Good evening to everyone present here with us today. This is Trion from IDCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Professor Dr. L. Srinivasa Murthy. Sir is MD, FRCP Edinburgh, FRCP Glasgow, FRCP London, FACP USA, FICP, then FRSSDI, PDCR, ACCR, Senior Consultant Physician and Diabetologist at Life Care Hospital and Research Center. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is optimal glycemic target, individualized treatment, goal and management. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. Thank you. I'm audible, right? I'm audible?
Yes, sir. You're audible and visible.
Right. Thank you. Good evening, all, and apologies for about 10 minutes delay due to the technical problem. And today we're going to talk about the optimal glycemic targets with the individualized treatment goals and what are the guidelines say. Basically, from a cafeteria kind of approach, we are going to the patient-centric approach. So we know the cardiovascular, renal, metabolic conditions definitely pose a high disease burden globally. And you can look at this slide where it talks about the burden of CKD, the cardia CVD, and the metabolic burden with the obesity. And very apt that there is a large unmet need in the treatment in spite of so much advancement in our treatment armamentarium with various class of drugs. Still, there is a definitive problem with the control. Just to start off, the projections of metabolic disease prevalence in India, you can see this is the latest ICMR India 17 study, which was published last year. And this is what it clearly shows that the diabetes and more than diabetes, the pre-diabetes is a greatest burden going to be in the future. And these are all the various cardiometabolic risk factors among the study populations which are seen, which is typically a thin fat Indian concept phenotype it fits into. So all metabolic non-communicable diseases except pre-diabetes were more frequent in the urban than rural areas. We know there is an increasing prevalence. There are recommendations from various bodies. Our own RSSD also have published guidelines regarding the diverse cultural and socio-economic background of Indians, and it has developed a therapeutic wheel with a patient-centric approach for diabetes management. In India, we have some peculiar problems with high prevalence of pre-diabetes, which I just showed, onset of diabetes at least a decade earlier compared to the Western population, lack of awareness about diabetes, there is a large urban-rural divide, sedentary lifestyle, which all of us are moving towards, then the cost of diagnosis, treatment, monitoring, prevention is again because of out-of-pocket market, unlike it's not supported by insurance, and there are limited resources setting, suboptimal knowledge about the guidelines for treating physicians, and physicians promote alternate therapies to retain patients. This is a sad part of our practice, which has come up quite recently. Despite multiple therapies, we know majority of diabetic patients have uncontrolled A1Cs, which is proved by the diabetes UKPDS 34, where there is something called Discover Study Program, which I'm going to show you, that globally 26% of the patients have had HbA1c beyond 9%. And higher proportion of them are in our country, which is tune of 35%. And about 17% only have achieved the so-called target of A1C 7%. Now, this is what I was talking about, the Discover study, which is early achievement of sustained glycemic control is a key component of effective management of diabetes. At poor levels of glycemic control at initiating second-line therapy suggests that the glucose-lowering treatment intensification is delayed in many countries. This is the gist of the study. It's called the Discover study, where the glycemic control in adults with diabetes initiating second-line glucose-lowering therapy is suboptimal. That means we all delay and we have the typical inertia. So look at the sequential treatment approach, which is compounded by inertia. So to add a third drug, it takes about 6-7 years. To add insulin, it takes beyond 7 years. and adding the latest so-called the GLP-1s or the pre-mixed bolus insulins, it takes another 3 years. So essentially, it takes about 10 years for the stepwise management to reach that whatever required treatment regimen for the patient. And similarly, this Panorama study, which is a cross-sectional study about glycemic control, about 5,000 plus patients in diabetics who are beyond 40 years, registered in the physician's practice in the Europe. This is just to look at the 1 AD, 2 ADs, 3 ADs, and insulin. You can see the patients not achieving the goal is definitely is a larger proportion. Even with the insulin and injectables, only 36% achieve the goal. And this is in the so-called the advanced or developed countries. And of course, we need comprehensive medical evaluation and assessment of comorbidities. This is what all the guidelines talk about, that the patient-centric approach, you need to be specific, you need to be achievable targets, you need to fix with various comorbidities, and it has to be realistic and time limited. So ADA 23 clearly talked about the medical care recommendation has to be multifactorial. The glycemia, the blood pressure, the lipids, and the CV and kidney benefits, apart from the lifestyle modifications, and education has to be the foundation. So this is what we talk about, the holistic approach or the patient-centric approach. We know type 2 diabetes is a progressive disease, and the onset of macrovascular complications can occur here. That is in the pre-diabetes regime only, before actual diabetes sets in. So this is the time where you need to tackle the weight, the dyslipidemia, hypertension, IGT. All these points has to be tackled in much earlier days than after diagnosis. So this has prompted evolution in the management of diabetes with the individualized A1C goals, evolving guidelines, treat to target options, multiple stepwise approaches, multiple agents with initial management. And this is what is required for all of us to know, that these evolving guidelines, evolving practices are important. So when managing patients, we need to select the drugs based on various factors like the variable expectation of efficacy, weight control, hypoglycemia, comorbidities, cost, polypharmacy, dosing and timing of that particular molecule. So there are a lot of challenges, and the most common reasons for resistance of changing therapy are these above factors. So we need to be individualizing the therapy with a choice of OAD, with a patient-centric approach. And for any diabetic patients, we need to look at what are the factors considered: age, BMI, CKD, duration of diabetes, established CVD, financial condition, glycemic status, hypoglycemic. This is very, very apt practical approach called ABCDEFGH approach from our own RSSDI. And the individualization of target, again, whom to have less than 7 or around 7, 7.5 is something which we should be aware about. For example, you see the less stringent, 7 to 8%. Severe hypoglycemia history, long-standing diabetes, limited life expectancy, very elderly, advanced micro or macrovascular complications, extensive comorbidities like CKD, who are on dialysis, etc. These are the set of patients where you need not be very tight. Whereas low risk of hypoglycemia patients, short duration, early diagnosis, long life expectancy, no significant comorbidities. These are the patients where you target less than 7, in fact, less than 6.5. We know the importance of reduction of A1C. Each percent reduction in A1C can give rise to all this. This is a famous PKPDS trial data, which we know. And the cardiovascular risk is greatest when both diabetes and nephropathy, occurrence of both these are there. This is the evidence which I'm showing. Steno 2 study was one of the earliest studies which showed the intensive multifactorial intervention can bring down the CV risk factors, absolute risk reduction when from the CV risk factor. So intensive risk factor modification reduces CV events to the tune of 20%. Declining renal function also increases the risk of hypoglycemia, which we showed. Severe hypoglycemia in turn causes adverse cardiovascular events, and that's something which we should remember. Obesity, again, it's an emerging field where it has been common CV risk factor in patients with diabetes. We know there are multiple basic pathophysiological defects which happens with obesity, like atherosclerosis, endothelial dysfunction, inflammation, fibrosis, arterial remodeling. All these eventually leads on to these complications. Metabolically healthy obese individuals have a higher risk of coronary artery disease, CV disease, and heart failure. So this is evidenced by this thin cohort study of 3.5 million individuals with mean follow-up of about 5 years. So metabolically obese healthy individuals with a BMI of beyond 30 without diabetes, without dyslipidemia, without hypertension, without diabetes, cardiovascular risk is 49%, 7% increase risk of CV, 96% increase risk of heart failure was seen in this. So it's very, very important if you diagnose somebody with a morbid obesity of BMI beyond 30, please remember this slide of increased reduction in the CAD, CVD, and the heart failure. Now, coming to the pharmacological approaches, the glycemic targets. I know it's a busy slide, but I'm sure most of you would have seen this many number of times. And this is what it clearly talks about the use of glucose-lowering medications in the management based on the ACVD risk, heart failure risk, and the CKD risk. And for the first time, they've also got, as you can see here, this side is a glycemic where choose the patient that provide the efficacy to achieve goals, achievement and maintenance of weight management. And when choosing glucose-lowering therapies, consider regimen with high to very high dual glucose and weight efficacy. That's very important. So early combination therapy is what people recommend. So how does this inform our guidelines? So this is what is something which is there. Good glycemic control, minimal risk of hypoglycemia, preventing weight gain, good patient compliance, risk of renal impairment, heart failure risk of cardiovascular disease. These are all the compelling needs when you see associated with diabetes, which you need to be putting up the goals. So the individual therapy, as I said, is has to be a patient-centric approach. And this is our own RSSDA wheel. For lack of time, we'll just quickly rush through this. The lifestyle modification is the key. And next comes the metformin. The green talks about all the available drugs. Yellow and red talks about the hierarchy system, how you can increase when you treat them. For example, you can see based on the age, it is safe to use. That is a modern SUVs. And of course, we need to watch for hypoglycemia. DPP-4 are efficacious. Minimal tolerability issues there. AGA is modest efficacy. SGLT2, good glycemic control. Restricted use with the glitazones. And basal insulins are effective and safe. GLP-1s, good glycemic control. So this is something which has been given for the BMI also. You can see the preference SGLT2, GLP, AGAs, DPP-4, SUs, and insulin is the last. So this is how we have divided, individualized the treatment. For example, CKD. And in the CKD, we have clearly given the EGFR range 45 to 60. Use caution with dose and follow renal function. With 30 to 44, maximum dose 1000 mg per hour, use 50% reduction is required. Less than 30, avoid use. Similarly, short-acting sulfonylureas, glyplazide, glycoside, moderate or severe renal impairment, you can use a low dose. Glyclazide, glimepiride, you can mild to moderate renal impairment, again low dose. And AGIs can be used up to 25 to 30. DPP-4s like linagliptin can be used at whatever the stage. Duration, early sulfonylurea, metformin are the most suited for tight glycemic control, especially when the sugars are high. Long-standing, you can have various other classes. The legacy benefits, please do not forget this Wikipedia slide, which clearly showed us the post-trial follow has given for the people who are in the intensive arm, the better outcomes with respect to the CV or the any diabetes endpoint or microvascular complications. A financial concern, this is RSSDA was one of the first bodies to come out with the cost of therapy to be taken into account. Now, all the guidelines, including ADA, talks about the cost concerns and choosing the drug. Sulfonylureas can be a good partner to metformin considering their cost. And also now, of course, SGLT2s have been very helpful because of the cost cutting. And of course, based on the glycemic the status, the insulins are the first preference when there is initial glucose toxicity or very high sugars, and the GLP-1s, SGLT2, PIO, DPP-4, SUs, AGAs, you can see in that order, the high glycemic efficacy are these drugs up to the SUs. Similarly, when hypoglycemia is a concern, you need to be watchful. The family members are to be educated, look at the special population, and these are all the drugs where the least risk of hypoglycemia is the DPP-4s, AGAs, SGLT2, and PIO. GLP, SUs, and insulin, of course, have got insulin. So to use this therapeutic will just to show an example. So based on the age, if it's advancing age, then you have the DPP-4 metformin AGIs. You can see this. And similarly, glitazones restricted, newer SUs safe to use, GLP-1s control, insulins basal safer than the premix. When you move to the B, the BMI, increasing BMI, you can see the overweight or obese consider that these class of drugs, and of course the next step would be these. When you say CKD, ABC, we are going through. Apart from lifestyle modification and metformin as an add-on, you can have SGLT2, DPP4, Lina, teneligliptin, ripaglinide is all safe with all stages. Similarly, advancing CKD, SUs, GLP-1s, limited use, AGIs, mild use, that is what we have shown here. Duration of diabetes, similarly established CVD, E and established CVD, you can see. Finances, you can see SU, metformin, pioglitazone, inexpensive DPP4, and the SGLT2 inhibitors. And G is with respect to the glycemic status. H is for hypoglycemia. So this is what ABCDFG approach. Now, patients with diabetes often fail to achieve the target with a single drug. This has been proved beyond doubt with the Wikipedia, as you can see. With the conventional therapy, people have slowly worsening over 10 years of time. So treatment intensification is very, very essential and integral part of our treatment. Now, this is again showing the glycemic targets with monotherapy can be difficult to achieve. As you can see, the 50% at the end of 3 years, and SUs, 6 years it becomes 30, at the end of 9 years it becomes just 25%. Why do patients fail to remain controlled with a monotherapy? Of course, apart from lifestyle, diabetes, we know it's a progressive disease, and that is where the beta cell function deteriorates over a period of time, and thus the requirement of drugs goes up. Now, the basic defects, we know omnes octa, the 8 defects, which has been identified by famous D. Franzo. So, addressing multiple defects would require a combination approach, because you cannot do this with a single drug. So, there is a substantial clinical inertia. Again, I'm repeating that when you want to switch on, this is what we do. It takes about 7 years for a patient to be on the third OAD, and another 7 years to be on insulins. So literally, the patient's lifespan would have finished by the time that the golden period, so-called, will be over. So the bad glycemic legacy will result, for example, you see the patients with A1C beyond 7%, not receiving intensification within 1 year, can end up with MI 67% of the times, stroke at 51%, heart failure 64%, composite CV endpoint 62%. This is what happens when you do not intensify the treatment if you see somebody's A1C beyond 7%. So this is the typical conventional therapy which we should overcome. And of course, good glycemic control delays onset of complication, and thus indirectly you bring down the cost burden, economical burden on the patients as well. And this is one of the studies verified which clearly showed initial treatment failure would be minimized with a combination. So to conclude, about 67% of the diabetic patients in India remove above their target. A delayed intensification can significantly increase the risk of MI, stroke, and already high risk of diabetes patients. Studies have clearly shown early intensive glycemic control reduces the risk of micro and macrovascular complications. And ADA guidelines and RSVT guidelines recommend use of combination therapy if A1C is above 1.5% above the particular glycemic target. And combination therapy definitely will correct the defects. And that is where combination therapy is most useful to start early. And that's most important, come out of the clinical inertia and start treating the patients in a right way. Thank you very much for patient hearing. Any questions, we'll be very happy to take it.
Thank you so much, sir. So we have some question if you like to take that up.
Yeah, please.
Yes, sir. So, sir, the first question is, what strategies do you use to address patient concern, preference, and barrier to adherence in diabetes management?
Can you please repeat? What?
Sure, sir. So, the first question is, what strategies do you use to address patient concerns, preferences, and barriers to adherence in the diabetes management?
Okay. See, it depends on the type of patient, whether the newly detected or a follow-up patient. For example, newly detected, they'll have depression, agitation. Some people will be a psychotic behavior. They're not, that rejection will be there. And this is where you need to involve the family members if available. to counsel them and show them some old patient. This is the strategy I use. You see patient 80-year-old sitting outside, he's been 25 years with my follow-up and he's doing good without any complications. All that in the initial, you need to spend little more time for the first visit of any patient who comes to you, because to get accustomed to you also will take time, number one. Number two, he's already fed up with, if he's a referred patient after 2 3 drugs and not coming, HbA1c not coming down, then the patient obviously will be in depression. So we need to show that empathy, that the acclimatization to our center, our doctor, that is yourself, and that matters a lot. So it definitely depends on the type of patient, whether the first patient or the follow. New patient, newly detected, are already on therapy, come from some other doctor's reference. So these are the strategies which you should look at, starting from your receptionist, starting from your study nurse. These are the people who will definitely pacify them. We will show that empathy towards them, and that itself takes them long way.
Thank you, sir. The next question is, can you discuss the potential role of newer medications such as SGLT2 inhibitors, GLP-1 receptor agonist, and dual-acting agent in achieving glycemic control while addressing cardiovascular and renal outcomes?
Yeah, I think this is a very good question, because the newer therapies, as I said, showed you a slide, inertia, there is inertia to start the newer therapies also. Now there is more than enough evidence to show the SGLT2s and GLP-1s have got the pleiotropic benefits for any given patient. So literally, except few absolute contraindications, the patients, apart from metformin, you need to be using. In fact, now there are papers which show that you can go to SGLT2 or GLP-1s even before metformin as a first-line therapy. To that extent, the evidence is coming up. On a lighter note, people now tell you can mix SGLT2 in a water tap and supply to everybody, every individual, even non-diabetics, because it has been showing the benefits even in non-diabetic patients. So using this at the early stages will give them a better benefits, I would say, rather than shifting to SGLT2 or GLP-1s at a later stage. You want to try them with SUs or metformin and then go stepwise management. I think we should not hesitate to start on these therapies based on the case-to-case basis at the earliest.
Thank you, sir. The next question is, how do you mitigate the risks of hypoglycemia when setting glycemic target and adjusting diabetic medications?
Yeah, I think I showed you a slide where which are the set of patients where you should think a relaxed kind of A1C, and which are the set of patients with a HbA1c less than 6.5%, where you fix up a target. So early diagnosed youngsters are the people with, in general, where you can set a target below 6.5%. Educational levels, their commitments, when you're talking to them, these are the other points we should look at apart from setting the target. Because if somebody is a busy, say IT, like in Bangalore, and person who is not able to do things like the diet exercise, then there's no point in setting for them, because he is not going to be obliging to you for your therapy. So such cases, you need to be very, very careful. You need to explain them about the risk of hypoglycemia when you're setting up a target tight control, what we call below 6.5%. So it's always individualized. Study the patient well, and then take decisions for the setting up the A1C target.
So there's one last question. How frequently should glycemic parameters, including HbA1c, self-monitored blood glucose, and continuous glucose monitoring, be monitored in different patient population?
Yeah. So basically indications for all the CGM or the A1C or the FBS people. So the glucometer is a must now for every diabetic patient. At least I insist in my practice to possess them. That's very important. Weekly once in 2 weeks is also fine, but they get a feel of it. That's very important to encourage them that this is going to be a lifetime companion for you, like diabetes. Monitoring is also equally important. A1C, depending on the patient's affordability, their economical status, etc., you need to decide 3 to 4 months once will definitely help you to moderate your CGM. Of course, again, availability, wide availability is something is not there. Cost is another factor, but there are set of patients where, example, you see A1C is high and FBS PPV is well controlled, or hypoglycemia, as the patient says, the very typical symptoms of hypoglycemia, but he is not able to monitor. These are some of the common simple indications for CGM. But every newly detected diabetic, if you can afford to use CGM, that will be great, which you can show them their improvement over a period of time, and that will again motivate the patients. So the CGM can be used as a motivational tool as well. Similarly, the whenever not CGM not available, whenever you can use the self monitoring of blood glucose SMBGs to motivate the patients.
Thank you so much, sir. And that's all from our audience. Before concluding, sir, any last remark from you?
Yeah, I think, as I said, the individualization of therapy is very important. Early combination therapy is very important. Using the right drugs at the initial stage of the disease process is something, is the onus is on us to prevent the complications of diabetes, and educating, spending more time with the patients, explaining about the comorbidities, the complications, the potential risks what a patient might have with the uncontrolled diabetes. The duty is on us. I think that is where the catch is, that we need to choose the right drugs at the right time for the right patient.
Thank you so much, sir, for joining us today. And with your permission, sir, I would like to conclude today's session. Thank you.
Thank you. Thanks for the opportunity, and good day to everyone. Bye. Thank you.
Bye, sir.